Well, I mean, this was such a great episode with Angela. She really just uncovered so many new ways of diagnosing, treating, and talking to patients about SIBO. And a lot of times when we read about SIBO, we hear about SIBO, or when we're treating SIBO, we're thinking, what more can we do? Like what new restrictive diet or what new antibiotic or what new antimicrobial? And I love Angela's approach of less is more. Like, let's just take a step back.
Yes, I got that sense too. And she's known as the SIBO guru, and for good reason. I really feel that she brings the art into her practice. And so she's not following standard protocols or algorithms. And I learned so much. I mean, I know about SIBO. I have for years. We know about the diets and the antimicrobials, pharmaceutical and herbal and otherwise, as you mentioned. But I think listeners, if you know SIBO, realize with this one, there's more to know. So you'll want to tune in. Hello and welcome to the Vibrant Wellness Podcast once again. I'm Dr. Emmy Brown here with the one and only Melissa Gentile. Today we're joined by a true pioneer in the field of gut health, Angela Pfeiffer. She's a functional medicine and licensed certified nutritionist and GI health researcher with 2 decades in clinical practice. And if that's not enough, she's also the creator of GutRx Guru's Bone Broth and founder of the Functional Medicine Shop. Angela is not just any nutritionist. She's an authority on gut health, specializing in the complex interwoven relationships between functional gut disorders, thyroid dysfunction, autoimmune issues, and small intestinal bacterial overgrowth, also known as SIBO. In fact, her expertise has earned her the affectionate title of SIBO Guru from her patients, and she is more than adept at dispelling the myths that surround SIBO and diet, which we'll dig in today. So let's dive into the fascinating world of gut health and with the SIBO guru herself, Angela Pfeiffer. Thanks so much for being here, Angela.
Thank you. Thanks for having me.
Angela, I'm so excited to dive into all things gut health, nutrition, and SIBO today, but I do want to get a little bit more into your background and how you got into this very niche part of the industry. So I know you started your studies in psychology, but how did you end up where you are now in such a niche part of functional medicine?
Yeah, absolutely. My goal was to become a PhD psychologist, and I was at University of Washington. I took the only course that they offer undergrads in nutrition. It was I think it was nursing and nutrition, or nutrition and nursing 301, if I remember correctly. And in a sea of 300 students, they're discussing hot dogs, hamburgers, and mac and cheese as major food groups for kids.
Oh, gosh.
And I realized, I didn't know everything I needed to know, but I didn't feel that that was the correct message. And I come to find out that just maybe, doctor along their journey might take that course, and that nutrition's not even really offered in their schooling as more medical doctors. Of course, naturopaths I know get a lot more, but medical doctors, not so much. And so I just flipped careers on a dime. And it was the complete luck of the draw that Bastyr University was nearby. I was looking at all the programs nearby because I didn't want to move. I'm a Seattle native, been here my whole life. And again, just luck of the draw. I'm not one of the practitioners that had a major medical issue that was fixed by alternative medicine that took me to Bastyr. I just didn't like what they were saying at the University of Washington for the master's program. It seemed very sterile to me, and I approached them a few times to discuss. And so I left, drove to Bastyr. The director took me in her office for about an hour, and it was just a no-brainer where I was going to go. And thank God, it was just a night and day difference in terms of an education.
You kind of knew something just wasn't doing it for you initially.
Correct. Correct.
I really just want to dive right into your specialty of SIBO. So I know that's kind of where we want to focus on today. So what really is SIBO? If you could explain to the audience, what it is and what do you think the root cause of SIBO is?
Oh, there's a long laundry list of that. So when we're looking at SIBO is small intestinal bacterial overgrowth. And basically it's an imbalance of bacteria in the archaea or archaea in the small intestine. It's an overgrowth in a place that isn't used to having an overgrowth. And what I mean by that is we've got, 1 to 4 hours of transit time where food matter coming out of the stomach is moving through that entire 20 feet of small intestine. And then once it hits the colon, it's going to hang out there for 24 to 48 hours. And there's so much fermentation that happens in our colon. That is a larger tube. It is used to being a little bit more stretched. Gases will move over the lining of the colon. We can expel those in our breath. And, it's kind of closer to the end where we could pass some gas. But if you get gas in the small intestine, it's a smaller tube. It's not used to being distended. And it is quite painful to get a really big, kind of bloat happening in the small intestine. And how that happens is bacteria in our intestinal tract, top to bottom, are fermenting off what we're sending down. So dietary fibers are coming down. They're using those as a food substrate, and they're producing gases as a byproduct. And so, we can take some of that happening, but on a larger scale, it becomes really a lot of pain, distension, belly bloat, people walking around with like they're 5 months, 9 months pregnant kind of feeling. Everything is tight. It hurts. And so those are some of the base symptoms that we see. And then over time, if that's left and somebody becomes chronic with SIBO and that bacterial dysbiosis that's happening in the small intestine, then we can start to see other things come up. It can uncouple B12. It can uncouple bile. So we can start to see some nutrient deficiencies happen with that, and effects, more effects on the immune system. It can interfere with our ability to, absorb food, just in terms of people start to really, well, first of all, they get kind of kicked into this chronic stress state that they were probably already in before they got SIBO. We can talk about that, but they get kicked into this chronic stress state, and then that's going to divert resources away from helping them digest foods. And then they're also adjusting their foods so much, and especially from a SIBO perspective, if they're stuck on any of the crazy restrictive diets, now you have somebody that's not digesting and absorbing that well, and now they're completely reducing the variety of what's coming in. And it really sets up this recurrent state that's sometimes really difficult to unravel.
And it's like a double whammy because they have the poor
Correct.
absorption from the SIBO, and then they're restricting their nutrients. Oh, gosh.
Yeah.
So it's a whole thing there.
Correct.
And what about most common causes? I knew food poisoning is a big one, but what else are we looking at, Angela?
Yeah. So, to me, those are a bit more functional in nature. We could, diabetics are at larger risk for SIBO. We can have people that have any kind of surgeries, short bowel syndrome. So there's some, surgical reasons. Other conditions could lead to this. Adhesions, if somebody has abdominal surgery, or if they have an ovarian cyst burst, there could be adhesions created from that. They're pulling on the small intestine, creating a pocket where you could have an overgrowth pop up. So those are some things. And then we look more from a functional perspective, and post-infectious IBS is, one of the more top root causes of this. So you get a food poisoning event. And what's common with all the food poisoning event exposures we can get with, Salmonella, Campylobacter, and so on, they all produce the same toxin. It's a CDTB toxin, cytolethal descending toxin. And that's what we really get sick from. That toxin is released, and now things are either going down or up and down, whichever way your body's trying to expel that food poisoning event. Around 10% of people, they might go on to get SIBO. And how that happens is the immune system basically mounts a response against that CDTB toxin. And in a small amount of people, there's going to be some cross mimicry where that attacks vinculin. And vinculin helps to connect the migrating motor complex along the small intestine, and helps to propagate those kind of earthworm-like movements down the small intestine. So usually about 3 months after a food poisoning event, it's out of your mind. That happened way long ago. You start to see these symptoms pop up because we start to see a slow transit, or slower transit time. So that's one. Clinically, I see parasites connected to this, but it could be, parasites, molds, like anything that's going to dysregulate the immune system, anything that's going to really drive someone into just hard-nosed sympathetic dominance. Because, if we look at the etiology around SIBO, it's linked with low stomach acid, poor digestive enzyme production, poor bile flow, poor motility. And if you think about what drives all of that, sympathetic dominance.
Right.
And I'm not saying that all these people have SIBO because of their stress state. It's usually stress and toxins and a major event that kick this in, whether it's mold exposure, whether it's they acquired some parasites, like something kicked this in. Because when parasites reside at that upper small intestine, as they do, or even in the gallbladder, they slow everything. They slow gastric emptying, they slow stomach acid production, they slow transit time. So we really have to take a very, very broad stroke when we're looking at where is this coming from for the individual. To me, this can never, ever, ever be treated on an algorithm because it first of all, it is a secondary condition. It's not a primary condition. And, as we look at SIBO and how it's become this weird beast that all of a sudden everyone's talking about SIBO, and I feel like it's so overly diagnosed. You walk into a doctor's office and many will, oh, I just don't like the breath test, so I'm going to give you an antibiotic. You have bloating, you have gas. This is likely SIBO. Here's the antibiotic.
Yeah.
It's kind of mind blowing when we're looking at it that way, right? So we've got all this recurrence happening because it's how it's being treated. I've seen patients where they unfortunately had to go on antibiotics for something else, and then their gut's not right after that. And then I'm thinking of a lady that I'm working with that she was put on Cipro for 2 rounds for something else.
Oh, wow.
And then whose gut would not completely dysregulate with that strong of antibiotic coming in with 2 rounds so close together?
Mm-hmm.
And then the doctor was like, oh, I think you have SIBO now. Here's more antibiotics.
Oh, no.
Right? But that's happening constantly.
Mm-hmm.
It's happening constantly. And it's just this weird place to be, even in the alternative realm. Like, why are we jumping on antibiotics? It's so weird. We have so much more in our toolbox. We're the ones that are supposed to look at root cause.
Right. And that's what it depends on. And you said broad strokes. So we're looking for that root cause. I think that's really key, Angela, for our listeners. And you mentioned a good number of them. I also have hypothyroid. So the autoimmune component might be there.
Sure.
Lyme disease might be there.
Sure.
So that's touching on the infections. You mentioned parasites also.
Yeah.
Opioid medications.
Mm-hmm.
Even traumatic brain injury I've seen cited as a
absolutely
contributing factor.
Yeah. Vagal nerve inhibition is strongly linked with this. Yep.
Yeah. So got to think about the nervous
system.
system.
I see all that too. And I see, that's why I mentioned mold, because I see that dysregulate from a brain perspective so much. And it's again, people will come to me after working through 7 different practitioners, and they're waiting for me to give them that protocol that will kill it after already being through 8 protocols that were supposed to kill it. And when I'm looking at their whole history, 10 years ago, you lived in a house with mold. Oh, this all happened 10 years ago. That was the onset of all of the symptom set. And yet SIBO was diagnosed at some point along that journey. And it just feels like every practitioner that they go to is looking at everything, but they're stopping on SIBO. Oh, you still have symptoms. Here's another antibiotic. Mm-hmm. It's very strange. It's very strange. When I do onboardings, they send me my intake paperwork. I have them send me any and all labs that they can get their hands on for about 5 years. And I sit down for an hour and, lay all that out into a flow sheet before I even talk to them. Because when we're looking at root cause, that health history timeline, and when the labs changed and all of that is where all the evidence is at. And what I see time and time again, I'm usually the 7th in line, maybe the 12th in line as a practitioner for when people get to me. I don't know if the other practitioners know that 7 other practitioners did a round of antibiotics, or did a round after round of herbals, where we all think is safe. And I love them, but we can still overtreat with those. And so I'm looking at the patient going, well, you just went through 7 rounds of stuff and it's not working and you're getting worse. Why is another round the next step? The next step is backing up and saying, what is causing this? And trying to unravel all the damage that all those treatments did.
Mm-hmm. And so I think we just answered this question, but it recurs so often. And that's probably because we're not looking at that initial triggering event or condition or dysfunction, right? And so that's
Correct.
all
Yeah.
that really good detective work you're doing.
Yeah, that's correct. So SIBO's recurrent because of the way it's being treated. That we have these algorithms that are stating, yes, run a breath test, but that's not what all practitioners are doing. Sometimes they're just treating empirically.
Right.
And basically the algorithm says treat 1 to 2 times. And then if that doesn't work, look for root cause. And Cipro is actually on the algorithm for treatment. Cipro.
Yeah.
SIBO is not an infection. It's an overgrowth in the wrong place. It's dysbiosis. So why is it there?
Right.
We have to ask ourselves this question. So, people basically are showing up at their doctors. They're getting antibiotics out of the gate. They're being told that this is a recurrent condition, which, what kind of mind messing does that do? If we look at placebo trials, it's obviously it's going to put you into more stress. I feel this way. I feel horrible and it's never going to go away. Thanks. Right.
Yeah.
And so it's antibiotic round after antibiotic round. And then they're handed these handouts on diet, which just are going to starve what out? They don't treat SIBO. None of them do. So that's to me why this is reoccurring. They're getting put on these really restricted diets. They're getting isolated. They're getting more stress thrown at them from every angle. They're being told this is recurrent, and practitioners are just hammering away with treatment after treatment after treatment after treatment. And I can almost forgive the one round of antibiotic because they're, again, that's just kind of commonly used suggestions out there. I don't like it. I think that this, we should not be using antibiotics for this for any reason. And so maybe one, but the second, the third, the fourth, the fifth, I've seen people on 7 rounds of antibiotics. I think the tops was 12. And that was over a 2-year period. I've seen, I would say probably GI doctors. I've heard this more and I respect them greatly. They do things I cannot go where they go. So we need everyone on the team here. It's just no disrespect. I love gastrointestinal doctors, but as I've heard multiple say, well, after like 3 or 4 rounds, you might just need ongoing antibiotics.
Oh my gosh.
And it's just, oof. Yeah, it's hard. It's hard to hear.
So do some patients see their symptoms subside while they're on the antibiotic and then they just recur once they get off? Is that kind of the trend?
Yeah. So, as we look at the studies, if you're ever looking up studies studies, you'd probably see what you're seeing. But when you hear from the practitioners who are running these studies at webinars, especially Pimentel and his group that are out of Cedars-Sinai, who have added so much to this field, highly respect them. They will also come out and just say, you know what, Xifaxan, it's 80% effective. And it's not. In the studies, it was, I believe, 43% effective. Then they put people through multiple rounds to get to that 80%. And then they're tracking people for 3 to 6 months. So it's just not long enough in terms of following these people. And when, it's usually if people are going to do an antibiotic, they might feel better while they're on it. They might do okay for a couple of weeks. They might be the lucky person that, they are better for 3 months, but it all comes back. And then they're like, oh, SIBO's back. I'm like, well, you just further dysregulated and then we're going to treat again. Let's further dysregulate and we're going to treat again. And it's not doing this any justice.
Right. And I'm sure your testing approach, Angela, is comprehensive because it has to be depending on the individual case and that root cause. And so I'm curious, we know breath testing for SIBO is the gold standard test. I'm wondering, when we're talking so much about getting to the root, when do you decide to do breath testing, if at all? I'm just kind of curious. I mean, your approach it's like a paradigm shift, which is so refreshing to hear. So I'm just wondering, like, when and do you even use breath testing? If you feel like, yeah, SIBO, clinically, we can see that's what's going on. But as you said, it's a secondary condition.
Yeah, I personally really like Eurodiagnostics for their breath testing. They use Quintron machines. You can go direct to Quintron as well. That's the gold standard for the testing that's been done and been validated. Most of the time when I onboard somebody, again, it's just the nature of working with people that have already been in this for a while. They're coming to me with 1, 3, 10 breath tests.
Okay.
I've seen other practitioners just, and again, full respect to all of us doing what we do. It's just an interesting observation. I feel like they're trying to treat, and it's not working, and they don't know what to do next. So let's run another breath test to see if it's here. And the symptoms are all still there, so I think it's being over tested as well. So I don't usually have the opportunity or motivation to run another breath test. I'm like, okay, that's been diagnosed. That's interesting. What's going on? And even if somebody came to me with 7 positive breath tests, I'm still setting them aside and saying what's going on.
Right.
We have to look at this person as a system, as we are trained to do, and help to reinstate, all those digestive steps from top down, mitigate their stress, set the foundation. So at the point that if and are you're going to instigate some sort of chill phase, that momentum is there. And what I find with this, I'm sorry, but stupid algorithm is that nothing is reinstated from a functional perspective. All of that is still there. And then an antibiotic is being thrown at it. What is that going to do? It's not going to correct this low stomach acid and digestive enzyme production and bioflow and motility and stress mitigation and vagal nerve issues. You're going to throw that into the mix. You might feel better for a short period of time. And then it's going to all come roaring back because the foundational piece wasn't addressed. And that's, to me, that's really foundational to address with every case. And then what is causing the slowdown? What's causing the lower stomach acid? Like, we still have to find root cause and issues. Those inhibitions with the digestive tract are definitely contributing to it, but what's causing those?
Makes sense. Absolutely. And you mentioned food poisoning as a contributing cause too. So I just want to throw out there the anti-cytolethal descending toxin B, that mouthful, and antivinculin, those can be tested for too. But and I think that's helpful when someone's so frustrated because these antibodies do impact the migrating motor complex, as you said. And one event of food poisoning increases your chances of then getting food poisoning again. But, it's kind of like common sense when it comes to trying to limit our risk to food poisoning. So I just think there's a time and place for these things, and that could be helpful.
Yeah.
But as you're saying, the foundational piece is huge, and you can get a lot of that information in terms of digestion with other testing too. So I'm wondering, how do you assess for that foundational piece?
Yeah, I run the Candida profile and IBS Sure with Vibrant quite often if there's a food poisoning event and the timeline is similar. I'll say with Candida, we don't have a way of kind of breath testing, if you will, for Candida. We've got to basically do an aspirate and pull that out. And those aspirates that could then be cultured can get contaminated as they're coming up through the throat and the mouth. So we don't have just like this perfect way of testing for Candida in the small intestine. And yet when they have done studies where they've looked at that aspirate, it's anywhere from 50 to 70% of people that had SIBO also had a fungal overgrowth in their small intestine, which again would then push back against the antibiotics because, maybe the quote non-responders to antibiotics or people that have yeast issues as well in their small intestine, and you just made that worse by doing an antibiotic.
Gosh. It's just
so I use that. I really love the gut zoomer. I do a leaky gut test on most people. If they already know they don't, if they already know they react to gluten, I don't usually run the wheat zoomer portion of that. I just do the leaky gut and the gut zoomer. And, from that, just wealth of information from looking at the total phyla and everything. I think what's interesting on the stool test is all of them at this point are mentioning SIBO. And I think as practitioners, we just need to understand we cannot diagnose off of a stool test for SIBO. Right. Stool testing is looking at the 5 feet of large intestine, not the small intestine. I really urge, any practitioner in here that's doing anything with SIBO or kind of focusing on the health of the small intestine to go look at the Reimagine studies out of Cedars-Sinai. they basically created it's an aspirate tool that is sterile, and they're only using it in studies. You can't just get this outpatient. So they're going in and actually testing the duodenum, the jejunum, and going as far down as they can, pulling them back up in a sterile way and looking at the makeup of the flora in the small intestine versus large intestine. And they state very clearly that there's tremendous differences between the small bowel and the stool microbiomes. And a quote from their study is, "Our findings demonstrate that the small bowel microbiome is unique and the stool is not a surrogate for the entire gut microbiome."
Mm.
And there's massive differences between the phyla in the small intestine and large intestine that I think we have to take into account, because stool testing, it's not cheap, but it's easy. It's easy to access, right? We're not going to send all our people in to get aspirates in their small intestine, but, so we're always looking at stool. But the reimagined studies are finding that in the small intestine, 90% of the phyla were Firmicutes, Proteobacter, and Actinobacteria. And in the stool, 90%, as we know, are the Firmicutes and Bacteroidetes. There's huge differences there. The Firmicutes in the small intestine, almost 70% were Lactobacillus. Firmicutes in the large intestine, almost 93% were Clostridiols. Huge, huge differences. One thing that I pick out on the gut Sumer that I really like is looking at the makeup of the phyla. And when Proteobacteria is above 5%, that's giving you a really big clue that there's a issue with the stomach acid, because Proteobacteria makes up like 35% of the mouth oral microbiome.
Oh.
And when that passes, every time we swallow, we're passing those bacteria down. And if the stomach itself isn't clearing those off with, good stomach acid and good enzyme production everywhere, that's going to make it through, and that can colonize. And what's interesting about it, it'll push out Firmicutes. So Proteobacteria will go up, Firmicutes will go down. And that's just a clear, I see Proteobacteria in the, 14, 15 percentile all the time. And so we need to, it's, to me, when we see that, the next step is not antibiotic. The next step is correcting the low stomach acid and trying to figure out why they have low stomach acid.
Sure. I think oftentimes we see poor digestion at people of all ages. And when I see so many of these reports, digestive insufficiency is really a huge functional disorder that I think is overlooked so oftentimes, especially in the context of SIBO. So again, that's kind of getting to that root, and you can really assess that digestion with the stool test. So thank you for walking us through that.
Yeah.
And Angela, I do want to kind of backtrack a little bit to when you were talking about your patient intake, and you kind of like put the testing aside and you kind of ask the patient, okay, like what's going on? And once you start a kind of treatment protocol and plan of action, I want to know, like, what are your insights or what's your philosophy on nutrition? I know you mentioned you really don't like all of these crazy restrictive diets, but there's some recommendations that you do make to anyone struggling with suspected SIBO or other GI conditions?
Yeah, absolutely. We just need to take this on a case-by-case basis. I'd say in the majority of people, obviously, people are dealing with chronic symptoms. If it's just a gentle underrumbling, we can kind of clean up their diet a bit and kind of hold them steady while we're working through everything else. If the symptoms are so debilitating that they're all over the place, obviously we need to figure out what we might need to adjust from a diet perspective. What we don't want to do, and this is across the board, is stick people on restrictive diets. I've done extensive research and education around the low FODMAP diet. I'm happy to share a 1-hour webinar I did walking through all the evidence for the low FODMAP diet specific for SIBO, looking at what it can do with the breath test, with hydrogen and methane and so on. So I'm happy to share that as a link, because I think it's so important for us to look at. When we look at the low FODMAP diet, the SIBO specific food guide diet, and the biphasic diet, none of those diets treat SIBO. They don't treat SIBO. We don't see with any study on a low FODMAP diet. And why I'm grouping those other two in, because the other two diets are more restrictive than a low FODMAP diet. The SIBO specific food guide is a combination of the SCD diet and low FODMAP diet. And then the biphasic diet basically took the SIBO specific food guide and laid it out in phases. So those are more restrictive. So when we look at them across the board with every single study, methane levels do not go up or down depending on a low FODMAP intervention or high FODMAP intervention. 0. And in the high FODMAP intervention, some studies do a true food intervention. The vast majority of them are putting people on a low FODMAP diet and adding 16 grams of FOS, fructose oligosaccharides. And the average person usually consumes, like a healthy individual, not enough fiber. We all know that, but the average person consumes like 1.2 to maybe 3 grams of FOS in a day. So they're giving these people massive fiber in this FODMAP group. Methane does not go up. We know with every single hydrogen study, I walk through every single one. They don't prep for the breath test correctly. They will have people eat while they're blowing their breath through the breath test, like eat, not like at the same time, but they'll eat all day long and they'll blow on their breath test. Like that makes no sense. And then they'll basically analyze it. When we're analyzing a lactulose breath test, we're looking up to the 90-minute mark, maybe 100-minute, depending on the test and when those intervals kind of hit. So that's what we're looking to see, if there's a 20 parts per million rise over the second marker with hydrogen all the way up to that 90 or 100-minute mark. That's diagnosis for hydrogen. And then methane is really depending on what camp you believe. Pimentel's group wants it to be 3 parts per million at any stage along that entire intestinal tract. I find that ridiculous. I feel like it's just going to lead to more people being on more antibiotics when we're looking at something like that. The North American consensus is around 10 to 12, depending on what year you're looking. So methane is more of just mere presence across that whole timeline up to the 90, 100-minute mark. Now they changed it recently. So now it's SIBO with hydrogen, or it's intestinal methane overgrowth, where they're looking at the entire tract. And again, I think a lot of people are just getting overdiagnosed with that as a whole. But yeah, they need to, they're all over the place, and they're really, really bad. There was a Shepherd et al. Study that I include in the write-up that, I'm so sorry, pardon me, that was not a Shepherd, it was Ong, that I include in the write-up, that actually provided food. And it's honestly, that's the best way of doing it. It's not just, hey, I'm going to educate this group of people and they go off and do it on their own. They provided the food. I mean, that's a beautiful controlled study.
Sure.
Well, they provided the food for 2 days. And for low FODMAP, it's under 9 grams is the goal with the study. And no one out in the real world is eating less than 9 grams of FODMAP when they're looking at the Monash list or looking at the FODMAP list and just putting their meals together. Nobody's doing that. So no one's really, it's bad because it's restricted, but they're not as restricted as these studies are. And so if the study can't do anything, it has no statistical significance, there's no change, the study design is horrible, they're eating while they're doing the breath test. So it's completely nullifies the results. Eating way more out there is probably not going to do much either. Basically, the food they provided were rice flakes, orange juice, pasta with red sauce. That was their low FODMAP. Yeah,
Yeah,
it's
super
horrible.
restrictive. Yeah.
Absolutely horrible. So if we are to believe this, there's put people on that for 2 days, and it's just not even a long-term study to look at. But if we're to believe this, we're going to cause diabetes in people that help them with SIBO. I mean, it's kind of silly. It's unreasonable to expect people to try to hit any level of a quote low FODMAP diet. And I think what it really sets up is people fear food. Quote, I can't have that because it's on the list. And they have no idea if they even react to it. And so it puts people in a really bad place. every single study shows that a low FODMAP diet makes people more dysbiotic. The one study that showed that a low FODMAP diet actually increased bifidobacterium, lo and behold, they were giving a lactobifidobacterium probiotic at the time, and they didn't do a washout period before they tested their stool. So they could have just been testing the probiotic.
Interesting.
Yeah. It's really, really bad. I go into depth on another study in that webinar. It was by McIntosh et al. And the entire conversation around a low FODMAP diet lowers histamines is based on their study. And they looked at lactulose breath tests, they looked at stool microbiome, and they looked at histamine. And with every single step, there was no difference when they compared baseline to post-data intervention. So they threw out baseline.
Wow.
Who knew you could do that? Then they compared post-data intervention, and there was no statistical difference in every single thing that they tested. So what they did was they had like 30 people that they tested for stool. They had 34 people they tested through for the histamine piece. They whittled those down into subgroups, and they divided them, what I'm counting is about 8 times, in gender, age, all the subtypes, and other baseline markers that they were kind of big on but looked like they had done. So we're comparing 2 people to 4 people, and they're making all these claims. It's really, that's what the studies do around FODMAP. It's very strange and was very enlightening. What we know right now, we don't know that a low FODMAP diet lowers histamine, because that study did not find that.
Angela, what about using these diets for symptom support? Because it's clearly not a treatment option, but I'm curious, and they are so restrictive. So do you ever use them? Is there a time and place? No. So like low FODMAP we talked about. Low fermentation is another one.
Say it again. I'm sorry.
Oh, low fermentation. So that's the Cedars-Sinai low fermentation diet. There's a lot of them when we're thinking about IBS and SIBO, and generally they're used for symptom support. So I'm wondering, do you ever employ those when you're looking for root cause?
Yeah, I don't ever.
Okay.
And I will say most people come to me on those diets already, and I am trying to get them off.
Yeah.
Day in and day out. And I would say if somebody came to me not on that diet and they had symptoms, we would go about it in a different way. Are they just reacting to fructans? Do they know if they have lactose intolerance? Do they know if they have fructose intolerance? Those are the main ones that people usually react to. I have them food journal. I'll track things. I'll look at patterns, so I can usually pick things out. But when we're looking at the studies with low FODMAP, short-term studies make people more dysbiotic. So when we look at SIBO, sorry?
I said, I just said, what's the point? Even if they feel better, it could be something else, or it could be a sensitivity.
I hear you on that. So it creates more dysbiosis. We're going to drop polyphenols, antioxidants, and short-chain fatty acids by doing it. The studies are very mixed on short-chain fatty acids going up and down. There's not clear, perfect evidence on this, but the studies are actually not, they're poorly designed, and they're short-term on some of them where I don't think they're going to get a reading on it. So just to say that, I obviously want people to feel better.
Sure.
And I think we can work on cleaning their diet up, try to clear up some of the myths around SIBO. A lot of times people for SIBO are trying to space their meals out so much, they're eating much larger meals out of sitting. And we've got studies looking at migrating motor complex. Those studies don't mean that we're going to have to eat with the meals spaced out. It means that people need a prokinetic, and that can be really helpful. And most everyone I work with is eating consistently across the day, and then eating before they go to bed, because they're waking up with insomnia. They're waking up with hot flashes and these adrenal reactions, and they need protein before bed, or even resistant starch to help them sleep. I work with a lot of people that are in a wasting state after going on this diet. So I know we want everyone to feel better, and I respect that very, very much, but the diet does more harm than good, and it gets them stuck on the diet.
Really, risk versus benefit.
I honestly do not see a benefit unless the symptom, they've got multiple autoimmune. Their symptoms are so all over the place. We can't pick any of those patterns out. There might be more altering to the diet that needs to happen for that. Again, I'm not going to leave somebody feeling that way. We will work on correction. But one thing I think that can be helpful is I might have them eat their regular foods across the day. And then depending on when they get the biggest flare with symptoms, maybe we do elemental diet for one meal to give them a bit more of a fast. That might be something to add in. The low FODMAP diet should be an elimination diet. It's 3 or 4 weeks on the diet. And then you challenge everything. But again, when I look at the studies, plenty of them, even up to 4 weeks, are showing more dysbiosis. So I think more about the majority of people with SIBO are already dysbiotic in the first place. They already have issues with that digestive steps. If I correct this and calm inflammation down and support the digestive piece, maybe cooking some of the foods longer to increase their digestibility, making sure people are actually chewing.
Yes.
What a concept. Most people aren't, we always should be asking as practitioners, do you see intact pieces of food coming out in your stool? Yeah. And they're like, yeah. And I'm like, you're not chewing enough. And we've got a breakdown. We know with those steps, we have a breakdown. But, we need to get people chewing more. And then if you're giving them the right enzyme that works and recovering stomach acid and supporting motility and working on stress mitigation, usually the digestive piece improves. And we don't have to go to something so drastic that's so isolating and they can't eat when any other family member's eating. They can't go out to eat. It's just so isolating.
It sounds like your kind of approach to everything is just like a breath of fresh air for SIBO patients who've been kind of going through all this craziness where it sounds like sometimes even years on end. And it's wild that lifestyle piece is such a crucial part in the digestive process because our lifestyles have gotten so stressful and so crazy. We're eating on the go. We're eating in a stressed state. Who knew? Okay, just chewing your food can make such a large difference here. So I love that approach. And before we wrap up, Angela, I do have one other last question, just kind of zooming out a little bit. What are some tangible tips that you have for listeners who want to improve on their gut health? I know this is really kind of on an individual basis. So what are a few things that you think maybe everyone should kind of be looking at, either including or eliminating?
To improve their gut health. I feel that obviously just as practitioners, we should be beating a drum of cleaning up the diet across the board, getting seed oils out of the diet. Some are going to need to go gluten-free. I don't think gluten's evil. I don't think dairy's evil. We just need to take case by case. If there's autoimmune, if there's leaky gut, I'm absolutely pulling gluten. If they have a known reaction, we're obviously pulling gluten. So, we definitely clean the diet up that way. I really like bitters. Bitters can be so absolutely supportive. And I work a lot on stress mitigation and I really go top down with that. So, I'm asking all my patients, what brings you joy? How much are you researching? What's the experience around eating? What do you do? Are you sitting at your desk working? You turn and go get your food, you bring it back and you continue to work. Just having those conversations and figuring out where we can put a few things in place. I have people take about 10 minutes before they eat. They're shutting down work. They're going and playing music from their teens or their early 20s where their body just has this visceral reaction to. They know every word of everything. And who did you have plastered across your bedroom when you were little, or a teen? Go play that music.
Oh, I love this so much, Angela.
Just to kind of get them out of their head because your body goes immediately back into, that memory. How do we remember those songs? I cannot hear. They're from back then. If I don't hear that song for 20 years, I can still sing the whole thing the second it starts. It's just amazing the memory on that.
And smell too.
Smell too. Yeah, absolutely. Yeah, I always have. So another thing I walk people through is to actually look at their food, smell their food, think about what it's going to taste, take that first bite, and put their fork down and chew it until it's liquid before you swallow. That's all I want them to do with the meal. It sets the stage, it slows it down. So just things like that can really help settle things down. I think can be super, super helpful for the gut. But after that point, it's just we've got to customize this for each person.
Well, I'm so happy I asked you that question because that was just such a great little segment there. I love that. And I love the question that you ask your patients, how much are they researching? Because I think with a chronic condition, or I don't know, semi-chronic, I guess you could say, it's kind of hard not to. And that's probably increasing their stress levels a lot.
Yep. I completely agree. And I don't tell them not to research. I simply say, if that's your jam and you really want to do that, which I'm sure, again, you've been researching for the past 4 years, right? Most people are up on this, but they still want to keep doing it. Like, we're just going to schedule 2 times a week where you have an hour. 2 times a week, you have an hour, you get to dive into anything, but I want you out after that. And I need them to unsubscribe from all the stuff they're receiving.
Boundaries, super important.
Right. Because it's just, what's that? Shiny thing. And then they're off on their own. They're not, they're not working with you as closely because they're like, oh, this person said this, and it doesn't even pertain to their case. So I respect completely that people need to educate them on what's going on with their body 100%. But especially with SIBO, we have information overload online. And again, as we look at this as it pertains to, the overuse of antibiotics and treatments, treating this like a primary condition, not even testing and treating out of the gate, putting on people on restricted diets, putting people, telling people, kind of messing with their mind and saying, well, this is recurrent, good luck kind of thing. That's stress enough. That's stress enough that just gets people into a place of losing hope. And it's really sad.
Well, Angela, today's episode was filled with so many good pearls of information, and you shed so much light on an area that I think is just kind of not educated well enough in this field, in this industry. So again, I thank you. And where can our listeners find you if they want to learn more about your methodologies, possibly work with you, or just want to know more about your work?
Yeah, absolutely. My site is SIBOguru.com. And then I also have functionalmedicineshop.com, where I offer access to the Vibrant testing and then professional supplement lines as well.
Awesome. And listeners, we'll make sure that we link this in the show notes for you so you got easy access. And Angela, before we wrap up each episode, I'd like to ask all of our providers, what does it mean to you to live a vibrant life?
To live an authentic life. And be accepting of yourself wholly.
I love
Loud and clear.
Yeah. Well, thanks, Angela. Thanks for all the insights and education today. I learned so much on this episode. And listeners, thank you so much for tuning in. And until next week, I'm wishing us all vibrant health and wellness.
Thank you so much for being here today. Don't forget to leave us a review and subscribe so we can continue to pay it forward together. And remember, the key to longevity is knowledge. Keep learning, growing, and tuning in to the Vibrant Wellness Podcast to discover the latest insights and strategies for optimal health. Join us again next week. Just a reminder, this podcast is for educational and informational purposes and is not a substitute for professional medical advice, diagnosis, or treatment. The views expressed by guest and host are their own and do not necessarily reflect the official policy of Vibrant Wellness. As always, consult your healthcare provider before applying any recommendations that you heard here today.